Thank you very much for this opportunity. I'm very honored to be in the esteemed company of the other speakers, and I congratulate the HUMLOG Institute on the celebration of the anniversary. It's really a pleasure to be here. Today I'll be speaking just a bit about my thesis on the design and analysis of public health and humanitarian logistics systems. I want to acknowledge my advisors, Ursula Mergen and Julie Swan, at the Center for Health and Humanitarian Logistics at Georgia Tech, where this thesis was completed. The thesis is presented in three parts, but they fall under a single theme. And that theme is that quantitative logistics methodologies do provide insights about managing humanitarian systems, and that studying these systems advances the underlying theories at the same time. So there's a very nice balance between theory and practice in this field. And I'm quite pleased that the parts of the thesis demonstrate that balance. There are three principal components. In the first part of the thesis, we introduce models of decentralized beneficiary systems. And in the second part, we generate some policy insights from the application of these models. And then finally, we introduce a case study of effective hurricane response operations in the United States. And as you can guess by just these brief descriptions, the different components fall more or less into those two parts of the theme, but overall are still unified in that way. I'll begin by talking a bit about parts 1 and 2 because they're very tightly linked, and then sum up with part 3 at the end. In parts 1 and 2, we are specifically concerned with this idea of decentralized beneficiary systems. And in contrast to what we might think about as a centralized system with a single decision maker, a commercial supply chain where there's an actor that can determine a system-wide policy to optimize an overall objective, in the humanitarian setting in particular, we're dealing with decentralized decision making. And we've heard this on the part of many of our speakers earlier today. There are many individual decision makers or agencies that are acting in this sphere. Each chooses its own actions according to individual objectives and the level of information that's available at the time. But these actions definitely impact the costs and benefits of the system as a whole. And as a result, the final outcome can be much more costly, depending on how we measure that cost, than a hypothetical centralized system. We recognize that complete centralization is not ever possible, especially in the humanitarian setting. And so what we want to understand through the application of the models that we develop is what is that gap between centralized and decentralized performance, and how can we design the systems in such a way to close that gap? We've already heard several examples of decentralization in health and humanitarian networks. I'll point out a few additional ones that particularly motivated this research. The first is that individuals often travel to supply distribution locations, and they decide which, among a number of facilities that might be available to them, the location that they will choose. Similarly, in terms of healthcare provision, families choose among the available health providers, households choose evacuation routes, and evacuees may choose which shelter they will stay in based on the number that are open and the routes that they want to take. And it was really our discussions about these types of problems with the Red Cross in metropolitan Atlanta in Georgia that led to our understanding that these kinds of problems weren't really being studied from a theoretical perspective. And we wanted to develop some models that would help to understand these types of systems. Right, so we see individuals are optimizing their own objectives, but their decisions impact the entire system. The tools that we bring to bear on this problem come from two separate fields. The first is optimization. Optimization has developed many advanced algorithms and has been successfully applied in commercial supply chains, but it historically has adopted a centralized approach, that single decision maker approach. Algorithmic game theory incorporates the behavior and decision making of multiple perspectives, but in the past it has tended towards being descriptive rather than prescriptive. And it has had a limited application to networks and large systems. And so our approach is to integrate these two methods to develop prescriptive optimization models for managing large-scale networks that incorporate individual behavior. The particular problem that we study in the thesis is one in which individuals are choosing from among facilities to receive supplies or services. So think about individuals choosing a vaccination location in the H1N1 pandemic or going to pick up supplies that they need because of a disaster. Individuals are choosing exactly one facility to visit, and as you might imagine, that choice is based on a combination of travel time and the number of other users at the same facility. So individuals are trading off between their waiting time or the congestion at the facility that they choose and how far they have to travel to get there. And different individuals or different scenarios might lead to different relative importance on these two different dimensions of the objective. From the system planner's perspective, right, the public health authority or the international community in terms of disaster, the total system cost of these beneficiaries' decisions depend on the entire travel time and facility congestion experienced by all of the individuals. A note about why we scale the utilities of these two different dimensions. First, it helps us to model some particular scenarios that are important in this context. The utility of distance versus congestion, of course, but differences in decision makers with respect to their access to transport, their desire to minimize exposure to a contagious agent, or the level of information that they have access to about facility congestion. There may also be perceived differences in the facilities, depending on the context. In a public health context in the United States, individuals may prefer a regional hospital over a local clinic or vice versa. There can be, in some situations, a stigma associated with treatment, and so an individual might not want to visit the facility that's closest to him in order to avoid seeing people that he knows. There may also be simply a different level of information available about the facility status at different facilities, and so these weights allow us to capture these realities. The focus of the thesis in particular is weights that are specific to facilities and that are applied to the congestion part, so that tells us the relative emphasis that individuals place on distance versus congestion. Just to solidify this picture in our minds, I've constructed a small example network. On the left of the network, we see the individuals who are choosing from among the facilities in the center. And they all want to receive service at one of these two facilities. Depending on the travel time between individuals and facilities, and on the total number of other individuals that are seeking service at a facility, an individual can calculate his utility or his cost, saying which facility gives the minimum cost to me based on my utility function that factors both my travel time and the congestion that I experience, subject to this congestion weight. Now, from the centralized planner's perspective, there might be a different distribution of individuals across facilities than what the individuals would choose on their own. And we see this in a couple of example assignments of individuals to facilities. So the congestion in the entire network, if the 4 individuals split themselves equally between the 2 facilities, is a congestion of 2 experienced by each of 2 individuals at each of 2 facilities, so a total of 8 units of congestion. But if individuals are choosing only based on distance or travel time, and that weight assigned to congestion is 0, then suppose that the first 3 individuals are slightly closer to facility 1, the resulting congestion at that facility is much higher than in the hypothetical centralized system, and facility 2 is only visited by 1 individual. On the other hand, perhaps there is something attractive about facility 2 that makes people willing to drive a little bit farther or travel a little bit farther to that facility, then we can see the opposite picture. And in any case, we see that the decentralized costs in the system are higher than those in the centralized case. An important question is by how much? And we're interested in solutions where no individual, after having seen the entire outcome of the system, would change his own decision about where he received service. In game theory, this is called a Nash or user equilibrium solution, and we want to compute 2 values related to this solution. The first is termed the price of anarchy, which is the ratio of the cost of the most costly equilibrium solution to that of the hypothetical central optimal solution. And the second measure is the price of stability. So how much do we need to sacrifice in terms of system efficiency to ensure that all beneficiaries are visiting a facility that is attractive to them? So the cost of the best equilibrium solution in comparison to that of the central optimal. The research questions that we address in the thesis are, first of all, do these equilibrium solutions exist for the system that we have defined? Can they be found efficiently? How do their performances compare to hypothetical central optimal control? And finally, the important part, what mechanisms or system design tools can be used to improve performance? The thesis provides positive answers on many of these questions. From the literature, we actually know that equilibrium solutions always exist. We prove that models for individual objectives that capture congestion weights always have equilibrium solutions that can be constructed efficiently in a computational sense. And we also introduce new results on these bounds on the decentralized performance. So this is a summary of what we were able to do on the descriptive side of the system. And in particular, we show that it is potentially very costly to operate a decentralized system like this. We show that there are constant bounds for some cases of parameter values, but these systems are arbitrarily inefficient in the general case. Of particular note, it's important when the utility levels associated with different facilities are drastically different. So if one facility is much more attractive to individuals than another, then this results in a drastic increase in the cost of the decentralized system. And the implication of this descriptive part of this thesis is that we need to design these systems in ways that account for this decentralized decision-making a priori so that the result of the decision-making is not too costly. And so in the prescriptive part, we introduce the idea of changing individuals' relative importance that they place on travel time and congestion to improve system performance. And we apply this setting to the H1N1 vaccine campaign in the US to derive some insights for practice. So the idea of improving decentralized system outcomes comes down to trying to think about these congestion weights as decision variables, values that we can control according to some choice of objective function. Depending on the context, whether we need to minimize the total change that's necessary in individuals' preferences or distribute these weights equally across facilities and so forth. But the constraint that we must satisfy is that what is optimal in the hypothetical central solution is also an equilibrium solution when individuals are making their own choices. Okay? And we show that this can be done efficiently in a computational sense for any of these and other relevant objectives in the humanitarian space. Now, what does it mean? Just a moment on this idea of changing weights. What does that mean? Well, in the settings that are relevant here, we can change the importance that individuals place on congestion by providing access to transport to facilities, so that individuals might be willing to drive a little farther or get a ride a little bit farther in order to spread the congestion across the entire network in a more equal way. So offering transportation services, offering additional services at facilities to make that visit more valuable for the beneficiaries as well, or simply providing information about the status of all of the facilities so that individuals themselves can make more informed decisions about which facility to visit. So that's how we might operationalize this type of improvement. The computational example that we present in the thesis applies this theoretical perspective to the H1N1 vaccine campaign in the US. And we specifically focus on data from the state of Georgia, which is in the southeast part of the US, where there were approximately 2 million doses of the vaccine distributed during the shortage period in the fall of 2009. these were shipped to approximately 2,000 different locations in the state of Georgia. We compare the centralized and the decentralized systems depending on the assignments made from a centralized perspective or the choices that individuals make in the decentralized model. In the centralized case, we require that all of the vaccines are used. From a centralized planner's perspective, we want to have the maximum impact with the scarce vaccine. And in the decentralized case, the weights associated with different facilities are a function of the number of vaccines available there. So the attractiveness of a facility to an individual depends on the probability that he will get vaccinated when he gets there. These maps may be a bit fuzzy in the back. The left are the results for the centralized case, and the right, the results for the decentralized case. And what I draw your attention to are the differences in colors. So red means that there are high travel and congestion costs in a region, and blue means that there are low travel and congestion costs based on the assignment of individuals to facilities. And what we see is that if there were a way we could tell everybody in Georgia where they should receive their vaccine, people are spread more equally and the distances that they travel are more similar. In the absence of such a dictatorship, the total distance and congestion when individuals are choosing facilities according to that utility function that we use is almost 9 times higher. And in particular, this red area here is metropolitan Atlanta. And in that area, there's not an incentive for individuals to spread themselves out more equally among the facilities because of the form of the utility function. In the decentralized system, moreover, there are some places where there's more vaccine than there are people willing to travel there. And this was certainly observed in the actual campaign itself. So how might we apply that idea of changing the weights on congestion in the pandemic case? Well, because weights directly correspond to the product that's available at the facility, we can move the available vaccine among facilities to try to encourage individuals to also distribute themselves accordingly. So changing weights corresponds to reallocating the product across facilities. Given solutions from the centralized and the decentralized, or C and D cases respectively, we find an allocation of the existing vaccine to obtain the centralized solution, but under the idea that individuals are still choosing which facility to visit. In all, the distribution of the vaccine is more evenly spread across the state, but in order to get individuals to choose the facilities that a centralized planner would have them choose, there are some places where we need to make the probability of receiving vaccine very high in order to get people to go there, and so we do use slightly less of the vaccine in total. But we see here the distribution of the vaccines across space is much more disparate than in our proposed solution where we have reallocated the vaccine across the region. Another measure that we weren't really optimizing, but that is very important in the humanitarian setting, is this idea of equity in individuals' experience when they receive or visit this facility. So we looked at the number of people per vaccine as a measure of scarcity at each facility. And in the centralized solution, with the actual vaccine distribution that occurred, we see that there is a wide variation across space. Here again, red means a very large number of people per vaccine, so an unfavorable solution. The decentralized solution with the actual allocation of vaccine is a bit more equitable, but when we implement the idea of changing the distribution of vaccine across space, the resulting scarcity that individuals encounter is much more evenly allocated. Okay. And in the thesis, we also describe some spatial statistical analysis on this equity measure to understand whether there are demographic factors such as income level, population density, or the number of people belonging to racial or ethnic minority groups that are associated with these inequities. And this particular piece of the analysis provides some insights for policymakers about how they might reallocate vaccine to avoid those inequities associated with certain demographic factors as well. With that, I'm going to step away from the parts that were much more theoretical and into a part that much more tightly coupled theory with practice. And that is part 3 of the thesis, which is a case study of Waffle House restaurants, which is a chain restaurant in the United States. The questions that we sought to answer through this case study were, first, are there private sector organizations that succeed in responding to disasters? And this question certainly came up in terms of partnerships with private organizations in the discussion with the earlier speakers. We also want to know what enables this success and how can the lessons learned by these organizations be generalized to others. The case organization, as I mentioned, is Waffle House Restaurants. And this chain is sort of a cultural icon in the southeast part of the United States. It was founded near Atlanta in the mid-20th century and has a total of about 1,600 stores across mostly the southeast part of the US. And being in that part of the US, it's very vulnerable to the effects of hurricanes. One side note about Waffle House, their dense presence in the southeast is such that when I moved to Atlanta to begin my graduate studies, somebody warned me that directions to anywhere that you go begin with turn left at the Waffle House. And it was only a mild exaggeration. So because of this, they have developed a very proactive approach to hurricane planning and response. This comes from the highest level of the organization all the way down to the local restaurants, with direct involvement of senior management, documentation of the lessons that are learned from year to year, and extensive engagement with suppliers, employees, community, and government. And in the thesis, we document these kinds of best practices and place them within the context of the crisis management and supply chain resilience literature, and learn that much of what Waffle House is doing fits very tightly with what is advocated in that literature. And furthermore, we expound on the ways that other private sector organizations can learn from these practices to advance their supply chain resilience, both for disasters and for other kinds of events as well. And I'll just sum up with this quote from the former president and COO of Waffle House that really tells the genesis of the success story of this organization in terms of hurricane planning. Nothing good can come from a closed Waffle House after a hurricane. Not for us, not for the community, and not for the associates. And so this really embodies their spirit of getting back in as quickly as possible, being operational, and building the supply chain practices that support this kind of activity. And so with that, I would just like to conclude and give my sincere thanks to the HUMLOG Institute, of course acknowledging my advisors and the others who had a role in guiding and funding this research. And I would be happy to take any of your questions.